Hello everyone, welcome back. This side Dr. Abhijeet Kumar, and today I'm going to discuss the pathology of pregnancy induced hypertension along with the question. So let's start. So the question says, what is the effect of PIH on GFR? So what is the effect of pregnancy induced hypertension on glomerular filtration rate? Whether it increased GFR, whether it decreased GFR, or whether GFR remains the same, or the GFR can increase or decrease. Now to answer this question, we have to first understand the basic pathology or the pathophysiology which is involved in pregnancy induced hypertension. So now starting with the pathology of the pregnancy induced hypertension, students remember that PIH is always due to placental pathology. Okay, it is always due to placental pathology. And now in this particular diagram, I have to show you, I have shown the diagram of a placenta. Okay, and you know that the placenta is basically made from the trophoblast only, the outer cell mass. The trophoblast differentiates into cytotrophoblast and syncytotrophoblast. So we have the cytotrophoblast layer, and along with that we have the syncytotrophoblast. Now this both layers, okay, they basically constitute the trophoblastic shell, and that is the primary villi. Okay, after that the extra embryonic mesoderm, which is actually inside the cytotrophoblast, okay, that also forms extra embryonic mesoderm. And apart from that, guys, later on what happens, that extra embryonic mesoderm, and after that basically there is invasion of the fetal capillaries. There is invasion of the fetal capillaries, and this is how basically the layers of placenta are there. Okay, so we have basically from outer to inner, it is the syncytotrophoblast, cytotrophoblast, extra embryonic mesoderm, and the fetal capillary endothelium. So this is all called as the placental membrane, okay, or the placental barrier. Okay, so fetal blood is basically separated from maternal blood with the help of this particular membrane. Okay, now everyone knows this, that this structure, it is of a villi. This structure, this is of a villi, and between two villi basically we are having the intervillous space. Okay, we are having the intervillous space basically between the two villi, and it is the space where the maternal spiral arteries will open, okay, or they will supply the blood. So maternal spiral arteries will actually supply the blood to the intervillous space, and the fetal capillaries are inside. Okay, so the placental membrane is the one which will separate the maternal blood from the fetal blood. And I told you this placental membrane, how many layers are there. Okay, now what happens, see, the cytotrophoblast, okay, replaces the lining of the maternal spiral arteries. Now what is the function of the cytotrophoblast here? It will try to replace the lining of the maternal spiral arteries, and what is the actual need of that? It actually converts them into low resistance vessels. So the volume of blood which is coming into the intervillous space will actually increase. Okay, so that process, it is called as trophoblastic invasion, because cytotrophoblast is the one which is involved in actually decreasing the resistance of these spiral arteries which are opening into the intervillous space. And ultimately, if the resistance is decreased, more blood will come into the intervillous space. So that is called as trophoblastic invasion. Now students, try to remember that trophoblastic invasion, basically it occurs in two steps. One actually at the time of 10 to 12 weeks of pregnancy, and the other one, it is around 16 to 18 weeks of pregnancy. Okay, so the trophoblastic invasion is occurring in two stages, one around 10 to 12 weeks and the second one around 16 to 18 weeks of pregnancy. Now what happens if the second round does not happen? Now if suppose the second round does not happen, so the trophoblastic invasion will not get complete, and ultimately it will be referred as incomplete trophoblastic invasion. Now, what was the purpose of trophoblastic invasion? So that the resistance in maternal arteries can decrease. But if it is not happening, if it is not getting completed, what will happen? Ultimately, the resistance in the maternal arteries will remain high. And if resistance will be high, less blood will come over there, and what will happen? The BP will increase, and you all know that blood pressure increases. It is known as pregnancy induced hypertension. Now coming on to the pathophysiology of pregnancy induced hypertension. Now everyone knows that if suppose the blood pressure in the mother increases, now what all other effects it can lead to? You all know that pressure is inversely proportional to volume. So if suppose the pressure is increasing, the volume will decrease. So ultimately the volume of blood which is coming to the intervillous space will decrease. And if suppose the volume is decreasing, okay, in the placenta will not get proper blood supply. It will lead to placental ischemia. Placenta will not get proper blood supply, and it will lead to placental ischemia. And now this placental ischemia, what will happen? It will act on capillary endothelium, okay, it will make them leaky, and the plasma will actually leak out. It will collect in the third space, and ultimately it will lead to edema. After that, it will also create small tiny holes, okay, inside capillary. Hemo concentration will be there along with the abnormal function of the platelets, and this constitutes the end organ damage. So basically the blood pressure which is increasing, it can have such a major effect. It can lead to the damaging of the organs along with the edema. So remember that the size of placenta is always smaller in PIH. I told you, because it is not getting proper blood supply, it will not be able to grow. So ultimately the size is small in pregnancy induced hypertension. Now students, if I supposed to know, if I want to ask you that the size of placenta, it is increased in which conditions? Yes, it is increased in diabetes, okay? It is increased in diabetes. Along with that, it is increased in twin pregnancy, okay? It is increased in twin pregnancy, and also the placental size, it is increased in RH negative pregnancy. RH negative pregnancy. So try to remember that the placental size will be increased in these conditions, whereas the size of placenta will be automatically small in pregnancy induced hypertension. So here the placental size is increased, or placenta is big. Now coming on to the differentiation of pregnancy induced hypertension. See, pregnancy induced hypertension, it is basically divided into two, that is the gestational hypertension and the preeclampsia. See, both of them share common features. What are they? The BP will be raised after 20 weeks of pregnancy, that I have already discussed in pregnancy induced hypertension. After that, the BP will not come back to normal within 12 weeks of delivery. That was, I talked before when I discussed pre-IH. Now, both the parts of pregnancy induced hypertension, whether it is gestational hypertension or whether it is preeclampsia, they will share these both points. But what extra you will find in preeclampsia, that it includes proteinuria, and along with that it will have signs of end organ damage, and none of these two things will be present in gestational hypertension. So gestational hypertension, it is simply the BP will be raised after 20 weeks of pregnancy, and BP will not come back to normal within 12 weeks of delivery. So it is only gestational hypertension, but preeclampsia includes these 2 points plus proteinuria or signs of end organ damage. Remember, I used the word or. It means that if any of the above, if any of these two are present, we classify it as preeclampsia. Okay, either proteinuria or either end organ damage sign. Okay, so any one of these two should be present along with these 2 points, so to classify it as preeclampsia. So remember students, preeclampsia can be further divided into mild preeclampsia and severe preeclampsia. See, mild preeclampsia, basically the definition says that blood pressure should be more than 140 by 90 or equal to 140 by 90, but it should be less than 160 by 110, and along with that there should be no signs of end organ damage. The signs of end organ damage should be absent in mild preeclampsia, whereas when we compare it with severe preeclampsia, remember students, the blood pressure, it should be more than 160 by 110 or equal to 160 by 110, and signs of end organ damage are perfectly present in severe preeclampsia. So now we have talked about proteinuria or end organ damage. So giving some important aspects related to that, to how to diagnose proteinuria. Remember that if suppose protein concentration, it is more than 30 milligram per deciliter or more than 300 milligram in 24 hours, okay, and remember that proteinuria is always pathological in pregnancy. Whenever you encounter a pregnant woman with proteinuria, it is not physiological, it is always pathological in pregnancy. Okay, whereas when we compare it with glycosuria, guys, glycosuria is basically physiological in pregnancy. Glycosuria is not pathological. Okay, so proteinuria is pathological in pregnancy, and that indicates that the pregnant woman is suffering from pregnancy induced hypertension. Okay, it can it okay, it can be mild or it can be severe as well. Now coming on to the signs of end organ damage. See, PIH or pregnancy induced hypertension, it is a multiple organ dysfunction. Okay, now PIH, if it involves the hematological system, guys, remember that it always there is a decrease in the platelet count. This PC stands for platelet count. Okay, so platelet count is always decreased. Okay, so if suppose the platelet count is normal, then we don't look for other parameters or don't look for other functioning of the organs. So the very first thing that you should look on, that is the hematological system, that you should look for the CBC, complete blood count. Okay, and in that case, if you found that the platelet count is decreased or it is less than 1 lakh, it means that the hematological system is disturbed. Apart from that, guys, remember the most common organ that is involved in pregnancy induced hypertension, that is again a question that I'm marking with a dollar sign, that is kidneys. And remember that how it is, basically the increased serum creatinine, basically more than 1.1 milligram per deciliter. So if the creat values or the serum creat values extend beyond 1.1 milligram per deciliter, it automatically like kidneys are disturbed, and it is the most common organ that is actually involved in pregnancy induced hypertension. Now if suppose actually it's a multiple organ dysfunction, and if suppose the liver is involved, now what will happen? Okay, so the liver enzymes will be increased twice than the normal values. Okay, so liver enzymes will be increased twice or more than 2 times the normal value will be there. Apart from that, what other things you can observe? You can see pulmonary edema plus cerebral edema, and that these all things, hematological system, kidneys, liver, pulmonary edema, cerebral edema, these all constitute the end organ damage. And this is proteinuria and end organ damage. That is again very, very important. Now coming on to a condition that in severe preeclampsia. So what is the definition of severe preeclampsia? Yeah, the blood pressure, it will be more than or equal to 160 by 110 mm of Hg, plus there will be signs of end organ damage. Signs of end organ damage. Now what happens? Now suppose there will be decreased blood flow to the brain. Now if suppose the blood is going less to the brain, okay, the brain will be deprived of oxygen and it can lead to cerebral hypoxia. Now cerebral hypoxia will again lead to convulsions, and this will again result in a new disease, that is eclampsia. That is eclampsia. Okay, so preeclampsia can lead to eclampsia. How? I just told you, decreased blood flow to the brain, brain will be hypoxic, okay, cerebral hypoxia will be there, it will lead to convulsions, and ultimately eclampsia will be there. Now along with that, if there is decreased blood flow to the fetus, now in the maternal spiral arteries are actually carrying the less blood, because what is happening, the resistance is very high. And why the resistance is very high? Because the trophoblastic invasion is incomplete. So ultimately the placenta will receive less blood, and less blood will be transferred to the fetus. So in that case, what will happen, the blood flow to the fetus will be decreased. And if the blood flow, or the fetus is not getting the proper blood flow, what will happen, the growth of the fetus will be decreased, and ultimately it will lead to IUGR, that is intrauterine growth restriction. Okay, it will lead to intrauterine growth restriction. Apart from that, remember that the renal blood flow inside the fetus will also decrease. So what will happen? The renal blood flow decrease, the glomerular filtration rate, okay? The glomerular filtration rate, it will also decrease. And if the GFR decrease, you guys all know that the urine output will also decrease, and ultimately it will lead to oligohydramnios. Okay, oligohydramnios we have already discussed in amniotic fluid part. Okay, so remember guys, whenever the blood flow to the fetus is decreased, the growth of the fetus will be hampered. That will again lead to intrauterine growth restriction. And apart from that, what will happen, the kidneys, basically the renal blood flow will decrease, the GFR automatically will be decreased, and if the GFR is decreased, urine output will decrease, and ultimately it will lead to oligohydramnios. Now I wanted to discuss some important aspects related to some other important questions. So what is the last organ to be affected in IUGR? That is the brain. Okay, and remember it is called as the brain sparing effect. Basically all the blood from other organs are basically blood from the other organs are transferred to the brain. Okay, so that is called as the brain sparing effect. Brain sparing effect. Okay, basically brain is the major organ, okay, which has to be saved. So what does the body of the fetus do? It will try to all the blood will be shifted towards the brain, okay, from other organs. So basically the last organ to be affected in IUGR, it is the brain. And what is the best ultrasound parameter to monitor IUGR? Yes, it is the abdominal circumference. It is the abdominal circumference, guys. Apart from that, now I told you, if suppose there is decreased renal blood flow in mother, automatically if the blood pressure is high, so there will be decreased renal blood flow. Pressure is inversely proportional to volume. There will be decreased GFR in mother also, and ultimately she will have oligouria, and oligouria basically indicates that urea, serum urea, basically in the blood, the urea, the concentration of the urea, uric acid and the creatinine will be increased. So in the mother, okay, the blood of the mother, in the serum, basically urea, uric acid and creatinine will be increased. That's again a question, I'm putting a dollar sign over here. Okay, so ultimately in both mother and the fetus, the GFR is decreasing. Okay, so in fetus it will lead to oligohydramnios, in mother it will lead to oligouria, and leading to oligouria simply indicates the concentration of urea, uric acid and creatinine will be increased in blood. It will not move out through the urine. Okay, so apart from that, the another important question that is asked, that is most important histopathological finding in PIH, okay, you will find that it is glomeruloendotheliosis. Okay, and apart from that, I have already discussed that what is the most common organ involved in PIH, that is the kidneys. So coming back to the question, students, what is the effect of PIH on GFR? So it decreases GFR. Yeah, already know that in PIH the pressure will be increased. So if the pressure, okay, the blood pressure is increased, the volume of blood what will happen to the volume of blood? Yes, students, it will decreased. Okay, so pressure increases, volume decreases. So ultimately, the volume of blood is decreased. It means that the GFR will decrease in both mother and the fetus. And remember, in mother it will lead to oligouria, and in fetus it will lead to oligohydramnios. Okay, oligohydramnios. And ultimately in mother, if it is oligouria, what you will find in the blood? Yes, the serum creat, okay, uric acid, everything will be increased. Okay, so that's the question of the answer. Thank you.